Hello, my name is Carlos Plata. I am a dental technician in Seville, technical director along with my sister at Plata Laboratories in Seville. We went digital in 2010, but that evolution reached the point that today we are completely digital. And we work in 80–90% of the cases with digital flow.
I am Ferran Llansana. I come from Mallorca and I am a specialist in oral rehabilitation, aesthetics on teeth and on implants, and nowadays I can't conceive to do most of the cases without a digital flow. And that's why we encourage you. We are going to talk about implants. And I encourage you to take this digital workflow. And we're going to start by talking about clinical and technical aspects of attachment selection. In this case, we're going to focus on interfaces. Maybe the workflow of single crowns, bridges, anterior aesthetics.
I do believe that this is the most difficult to learn to handle because of its variety, which has its motivation. But let's explain why we choose one type or another.
I would like to start, before you start with the technical aspects, on how implant placement has changed. In the past, we focused on external connections, the brain-mark external hexagon, which is still used today. And that hexagon was mainly used to carry and place the implant. Basically, it did not act as a grip, but the through screw was what retained the crown and gave us many problems. And these problems were translated into the fact that we accepted a bone loss of 1.5 millimeters in this implant. So we also made prostheses in other materials, metal, ceramic, as you rightly said. And as far as biocompatibility is concerned, it is not a material that we like. We do not like to place in a connection a metal that has an alloy that has more hardness than titanium itself.
In this case, we could comment that metal ceramic has been made a few times with titanium, but it was a much more complicated process and it was discarded. And when titanium has been made, it has been made with composite, except for a couple of technicians who are left in Spain making ceramics, but it is something that has been discarded for that reason.
The problem of the hardness of the materials with different hardness can corrupt or damage the implant connection, and this is irreversible. We see here the evolution from the external connection to the internal one, which would be like gaining retention. But above all, we are going to talk about the internal Morse taper connection, which will give us more biological sealing. We know that a bad connection makes a micro movement that makes a persistent inflammation, which we assumed in external connections as a normal loss. And it is precisely because of the connection. We also know that connecting and disconnecting the attachment. In the end, the hemidesmosomes, every time we connect a healing abutment, it generates an inflammation, and we do not want that. And that's why we started to perform the one-time-one abutment, which was to take the impression. This is from Dr. Vela, who made only one impression and only one disconnection. And from there, we tried to lose as little bone as possible. We see, Carlos, that the objective has always been to lose as little bone as possible in order to guarantee long-term stability. The process consisted in that we were making a second phase by pressure on this internal connection until we reached the closing plugs. And at that point, we took the impression and made a zirconia abutment. This is an old case. Look at the volume they had, right? Let's see what this translates to. It had nothing to do with the profiles we make today. The interface allows you with a metal. Mechanically, everything is more favorable, as you will explain. In this case, we did cementing. We didn't have so many angled screws. It is a problem to cement, isn't it? This is the before and after, an old case, always with the objective of not losing bone. But look at 2007, the first day I placed. There is a bone peak between the implants. Time goes by, the bone peak is lost, bone is lost through the abutment. That was mainly a question of the abutment not using these interfaces, not using the switching platform, condemning to the same diameter as the implant, a horizontal profile. And here we see the switching platform concept, a classic concept where we are not going to go into it too much, where it allowed to give, again, more space to the soft tissue so that there was no bone remodeling. And the current concept is to reduce the diameter to avoid bone loss. And we achieve this with interfaces and with zirconia, which, as you said, is a much more biocompatible material. In addition, we also know that we have to add soft tissue to guarantee that sealing, that protection.
We also talked before about the differentiation between anterior and posterior sector to differentiate between when to use a narrower or wider implant, because there is also a technical part that is purely physical, and that is how much pressure, how much force a crown receives, how much is transmitted to the interface, and what are the wall thicknesses and how much the screw suffers. We will have to come to a consensus to be able to have a narrow implant with a narrow profile without compromising the strength of the interface or excessive suffering of the screw.
Indeed. At the end, what is the load? I think that in the anterior sector, at the clinical level, we could use small diameter implants because of the mechanics that this implant will resist. But in the posterior sector, be careful with the concept. Let's not go for 3-point implants. Well, we can suffer later. I have seen 3 with 3. We can suffer the consequences of fracture, but it is not the fault of the interface. Maybe it is the fault of all the mechanics. Look also at the antagonist. Look also at the type of patient, if he is a bruxist or not. We must take this into account and not take it literally to reduce the diameter in all cases.
Immediate post-extraction implantation or not, in order to have a good implant placement center to distribute the forces.
Indeed, the planning that we also mentioned in the previous video. To summarize, we would say that the objective is to increase the soft tissue. As we see, in all cases, that will give longevity and less bone loss. We gain volume, as you see here. The depth of the implant. We won't have time to talk about this, but we have to go deeper. Why? To give the option to create an emergence profile. To give the option to take an interface with a high gingival height that will give us space so that sometimes even the bone can grow, and that the soft gingiva has stability. And to use, as you see here, interfaces that sometimes we have to even reduce. And to guarantee this emergence profile with all the materials and interfaces that we have been talking about, and that now you are going to describe to us, which is the most important thing, right?
We would have to talk a lot about materials as well. We are not going to be able to either. Materials, machined profile, polished profile, because of the better behavior of some materials with a soft tissue than others. But for me, when a job comes to the laboratory, there are several factors that are important or fundamental in deciding which interface to use. First, of course, is accuracy. There are many types of materials, many brands, and it is going to be essential that there is a good precision in the connection, because if we do not have that precision, we are going to end up with micro movement of that restoration that is going to damage the retention of the restoration. And it will even damage the head of the implant. We can end up with abrasions on the implant head apart from infections. The precision of the interface is fundamental. The gingival height, if we have a connection that can be valid but we do not have gingival height, we can find ourselves with an implant that is 4 millimeters deep and the interface is almost at the level of the restoration will not fit. And if it does go in, we find that since the termination of the interface is at the same level as the gingival ridge. The gingival ridge, we can even have horizontal fractures because it does not have the retention it should have. That is why cementation heights are also important. We can have 3.5, 5, 6.5, 8, and we are going to decide in each case how much gingival height we want and how much cementation height we want. The possibility of angulation is also important because there are times that due to bone needs, we are going to have to angulate. If we have it within the angulation possibilities, we will be able to solve it. There are times in a multiple, if we don't have direct angulation capability as much as necessary, we could put, for example, the multi-unit angled transepithelials. with which we will be able to angulate, for example, 28 degrees, and then we can angulate up to 30 degrees above. So we could also add angulations, and all this has to be taken into account prior to the work and the design.
But let me tell you, to add angulations, we need gingival height, yes.
Yes, it is important, but we can't always do it. Because when we put in a multi-unit of 28 degrees already, the external part, the part that angles already has 2, not 5. If we have a connection, 2 millimeters below we put a multi-unit, we will already have half a millimeter outside the gingiva.
That is why it is so important to plan the implant placement first.
It is fundamental. Thanks to that, we will be able to take into account the profile design, because, for example, he has this philosophy of very correct profiles so that we can generate a profile. But there are times when we find ourselves with a design without prior planning of the profile, and there we have to select how far we can go with an interface, so that according to the zenith of the proximal pieces, we can get a correct emergence to give aesthetics, and we will also have to take this into account. That's why we insist on knowing and taking into account all these factors before deciding which interface to use. Of course, reliability and robustness. If we don't have a resistor, our work is going to be compromised. And the possibility of a valid digital analog for me is fundamental, because if we have a digital analog that does not give us the correct height in the printed model, because it can be higher or lower, it can mislead us in the position of our restoration. This can be affected by many factors, such as the type of value we have chosen for the digital analog library. Depending on our printer, we will have to parameterize if it is possible, and if not, make tests to know where the analog goes. But if we have, as in this case, a side stop and a bottom stop, we will make sure that the analog is going to be in position, and when we do the work, we are going to have much more security than in an analog that is not completely fixed, either by rotation or by depth. In this case, I would like to talk about, I find myself with many doubts about how the nomenclature is used, how it's used, the different gingival heights at the time of selection. For example, in this case, we have here an interface, a Klockner Vega. It could have been any other, because the first 2 letters correspond to interface, as we will see later as well. Then the I corresponds to interface. If it's a scan body, it will be an S. If it's a screw, it will be a T. Interface is an I narrow platform. That all corresponds to the nomenclature of the platform. And then we find 2 little numbers. What are these 2 little numbers? In this case, 0, 0 is anti-rotating minimum height. Anti-rotary are named with even numbers, and rotary are named with odd numbers. Therefore, when we pass, we find one that has a greater gingival height. This one, instead of being 0.5, is 1.5. And how do we know which one it is? Well, in this case, we have 0.2. Minimum height 0, 0, even height next height 1.5, 2. By this same rule, the next height. 2.5 is going to be 4. They are all anti-rotary, they are even, they will have their cut heights that we can modify later. If we go to rotary, we have the same gingival height of 0.5, but in this case we have 0.1, because the rotaries are going to be odd. 1.5 is going to be 0.3, and 2.5 is going to be 0.5 by this same rule. So that we understand, some platform at this gingival height 3.5, so it would be the even 0.6, and the odd one would be 0.7. I think that by seeing this, we are getting much more of an idea of how the different interfaces are used with different gingival heights, and how we can select them in the software, which we'll talk about later in another video. And with these tools, we're going to be able to use the cutting heights. The anti-rotators come in at 8, and we have the tools to either cut, or we leave it at 8, or we cut at 6.5, 5 or 3.5. And in the case of the multiples, we're going to have it at 6.5, and we will be able to cut it to 5 and 3.5. And with that, we are going to have the possibility in the software to see what gingival height and what cutting height, and we will decide what we have to measure.
I believe that at the clinical level, we would have to communicate with an X-ray and say, Carlos, let's put a gingival height of 2.5 and then we would have the anti-rotational rotary workflow for the scan body. And another very important thing is that we clinicians have to understand retention, an implant that has not been in place for many years. It will have more clinical height, a longer crown. So the age, the height, what we are saying about cutting, we are interested in making it longer mechanically so that it is a body, a more resistant titanium core, and at the same time to avoid decementation. Cementation will be more effective the more cementation height we have. So that is the important thing. To summarize, it would be the gingival height. It is more the clinician who has to orientate you, and the height of the retention cut is the technician who has to decide to avoid problems. What we don't want is problems for us, neither cementation nor fractures. That is the main reason.
And it is important to have good communication because, for example, if we talk, because in this case we are going to put height 1.5, we will have to see if it is possible to achieve the profile that the clinic wants. From height 1.5 according to the proximal pieces. Communication is fundamental. In this case, we can see how for the angulations, there is also an angulation tool. And in this way, we have an interface that comes as standard with standard height. And then with the cutting tool, we will always have the same cutting height because that will allow the screw to have an access, and then the screwdriver can also enter until it is screwed in thoroughly with torque without bumping into the walls. That's why we also have the side cutting tool for screw access. It is indexed, of course, and makes it much easier.
At the laboratory level, yours as a stock favors you because the same gingival height can resolve angulated more or less retention. I think it is unique and an advantage.
We will simply vary the gingival height because the cutting height will always be at the maximum, and we will cut at the necessary height even the same because we will make the access for the screw.
Hence the name custom interface.
That's why. Yeah, totally. Here we see the possibility of angular that already comes out also in the software for angulation, so we can also correct other problems. And the only caveat that we like to comment is that in the case of the interfaces on multi-unit, not only the height that we have commented, but there is one of 3.5 and one of 6.5, and with all that combo of elements, we can make our digital models. Here we saw what Ferran also talked about. Of the different types of scan body for multiple units more than the digital ones, with their digital analogs, and we will be able to do this kind of work that, thanks to the intraoral scanning and the possibilities of the attachments, arrives to the patient in the morning with his teeth and leaves the same day or even the next day. Some people place it after 2 days. It depends on the philosophy of each clinician. To place our immediate load prosthesis in titanium, with an interface in titanium, and in this case they are PMMA, they are prior to the staining, but we give an aesthetic quality and quality of fit that was very difficult to achieve before. And here we can see our model printed with digital analogs and our immediate load prosthesis on rehabilitation.
And once again, the ease that digital gives us and the ease that it also gives us. With the same interface, we only have to determine the clinical laboratory gingival height.
The versatility that gives us the possibility to solve problems that we have always had, clinical, technical, or stock problems.
You can't have all the clients, you have all the implants. Imagine if you had to have all the heights, what would happen in the end? If you have a lower height than the one you need, maybe you would use that one because the immediate loading has to come out. But now you make it to measure for each patient. In the end, what we are looking for is versatility, and more so in the laboratory.
Versatility and minimizing problems as much as possible.
100%.